Hi there. So in chapter 36, we're going to be talking about adrenal steroids. And these are ones that you'll hear referred to as glucocorticoids and mineralocorticoids. These are what the adrenal glands secrete. It is, again, controlled by the hypothalamic pituitary axis. So to start off with, what happens? I'm going to try a different approach here because I really don't like the way the book is set up. It can be kind of jumping around all over the place, and I want to follow a logical stepwise approach for you guys. So again, the adrenal cortex secretes two different types of hormones, mineralocorticoids and glucocorticoids. The way it does that is it's that negative feedback loop again. So the hypothalamus will put out corticotropin releasing hormone. That tells the anterior pituitary to release ACTH, adrenocorticotropic hormone, which then tells the adrenal glands to release cortisol. So once there's enough cortisol in the body, that negative feedback loop shuts off the hypothalamus and tells it to stop producing CRH. So what would tell the hypothalamus too that maybe we need more? So the things that cause these hormones to be released are the sleep-wake cycle, negative feedback, and stress. So if a patient is under severe stress, whether it's anxiety, stressed out at work, or stress such as traumatic stress, they've been in an accident or they've been burned, there's an increased need for cortisol. So that is part of that feedback loop that tells the hypothalamus, hey, my body needs more, start producing this hormone that's going to tell everything else to happen. Sleep-wake cycle. When you are waking up in the morning, your cortisol levels are beginning to rise. Throughout the day, they rise, and then they slowly drop off close to bedtime to tell your body that it's time to relax. One of the side effects of cortisol, and any sort of steroid is agitation or restlessness, basically being awake. If you give somebody a dose of prednisone or hydrocortisone, it's going to wake them up. It's going to make them a little jittery, a little jumpy. They might feel like their heart's racing. So that's hopefully going to help you understand the sleep-wake cycle. Cortisol high, rising in the morning, and falling down at night when we're ready to go to bed. So those are the three things that will increase the cortisol levels in our body. Again, sleep-wake, negative feedback, and stress. So what do all these steroids do, specifically glucocorticoids? They regulate metabolism. They're a big player in the metabolic process. Specifically, glucocorticoids participate in two processes, gluconeogenesis and catabolism. Gluconeogenesis is making new glucose in the liver. Injured tissues, or tissues in general, and our brain primarily work off of glucose. Now that doesn't mean if you eat a big sugary meal you're going to be super awesome and wide awake. What it means is that it takes those healthy foods that we put into our body, breaks them down, and over time there's sort of a continual like store of glucose for our body to be able to use for our brain, for our tissues, for our muscles. So catabolism is that process of breaking down proteins into amino acids, and then gluconeogenesis happens in the liver, takes those amino acids and breaks them down into glucose. So all that big word means making new glucose. Genesis means to form, to make. Glucose means obviously glucose, and neo means new. So between those two processes, basically we're providing the body with energy. So what are corticosteroids used for? They're used for replacement therapy for someone whose adrenal glands might not function completely or might not function at all. And these people are on chronic replacement for the rest of their lives because these steroids are necessary for us to be alive. They're also used in treatment of inflammatory conditions. And you're not just thinking about swelling from maybe an injury that you got. We're talking about rheumatoid arthritis, in which our joints swell up, regular arthritis, in which there's sort of swelling all over the place. Some of the collagen diseases that are out there, if you have asthma, you might be using it to release the swelling in the airways. Sometimes they'll use it in traumatic injuries, spinal cord injuries, to bring swelling down. So there's a ton of different uses of these medications. Some people with common cold will have so much swelling in their airways that they'll be given a taper dose of prednisone to help bring that swelling down, and we're going to talk about tapering in a little while. So you might see half your patients on steroids. Sometimes it's hard to tell why. It might be a different reason for every single one of them because they do have a ton of uses. So moving on to table 36.2 talks about a couple different steroids that are available. Naturally occurring short-acting steroids, synthetic intermediate-acting steroids, and synthetic long-acting steroids. So those naturally occurring ones are ones that occur in your body as is. The synthetic ones are ones that were man-made, and they are able to act for longer, whether it's because they're broken down slower. They act longer than the ones that are naturally occurring in our body. So that'll help you get familiar with some of the names. As you can see, they all end in O-N-E. That's pretty common to this class, so it's a good way to tell if it's a steroid. 605, page 605, covers the various uses, the clinical indications of steroids, and I'm just going to read down the long list, so hopefully it'll give you an idea of how wide of a variety there are of uses. So, rheumatic disorders we talked about, arthritis, collagen diseases, specific ulcerative colitis, multiple sclerosis, severe allergic reaction, respiratory disease, management of leukemia and lymphomas. Can also be useful in the management of allergies. There's what's called off-label use too, and I want to explain that to you. Off-label means not FDA approved. Anything the drug is approved for is considered a labeled indication, and that was the list I just went over. So off-label means not FDA approved, and that includes bacterial meningitis, COPD, Graves, ophthalmopathy, respiratory distress syndrome, septic shock, and spinal cord injury. So even though the drug hasn't approved it for use for that indication, we can still use it because we know it works. It's just not been necessarily, given the go-ahead by the FDA. People don't get in trouble for doing off-label use. It is pretty common. You just have to have a little bit of evidence out there saying they've used this drug before to try and cure a disease or treat a disease, and yes, it has worked, or no, it hasn't. These drugs are available. Glucocorticoids, or corticosteroids, as you might hear them interchangeably called, are available in a variety of ways. Inhalation, intranasal, oral, IM, IV. There's a ton of formulations out there, topical. So you might see a variety of medications. The ones you might be familiar with are hydrocortisone topical. That's available over the counter, and people would use that on anything on their skin that's swollen. Let's say they've broken out in hives, they might put that on there. So again, just a variety of uses there and a variety of ways to get it into the body. Usually you go with the lowest effective dose, so they might titrate something to figure out what's effective and then stop at that dose. We talked about tapering earlier, and I just want to go over that for a minute. So steroids, corticosteroids, with long-term use, systemic use, they can cause psychotic breaks, what they call. Somebody might become more agitated, have an episode of acute psychosis. You might be familiar with that, what they call roid rage, and that's somebody who's using steroids to build up their muscles, and all of a sudden they turn into this crazy, nutty person, maybe not even like themselves at all. That is a side effect of steroids, whether it's steroids that you're using to build up muscle or steroids that you're using to treat a disease. My mom actually experienced it, so she no longer takes any sort of steroids, despite the fact that she has pretty bad respiratory function sometimes, and she's on nebulizers. So the opposite of that, if we were to take away the steroid that we are giving a patient, what we've done when we're giving it to them is we've replaced the need for the adrenal gland to function. We've basically taken over that and said, you don't have to make anything. So the opposite of psychosis, if we take away the dose that we're giving them as well, their adrenal glands don't automatically recognize that they have to start functioning, so there is no steroids in the body whatsoever, which again, if you remember, are necessary for life, and the brain functions off of the glucose that is created by those steroids. So if we take away quickly those steroids without tapering down, and I'll explain tapering in a minute, what we're going to put the patient into is a severe mental depression, which can be dangerous, very dangerous. It's called a crisis situation. So tapering. An example of a taper would be taking any random medication, starting off with 6, then going to 5, 4, 3, 2, 1, over a number of days. And they can stretch that out as long as they want to, however long they feel they want to taper something over. But usually it is, you're taking one pill away every 2 to 3 days. So that helps lower the amount of steroid in the body, and it tells the hypothalamus to tell the pituitary to tell the adrenals, hey, get back to work. We're not getting as much as we were. So they can do that with a taper, or you can also do alternate day therapy, which is where you're giving a tablet every other day. So day 1, you get a tablet, your glands aren't necessarily functioning. Day 2, that medication is out of your body, and now the glands are going to realize they need to wake up and start working again. So there's a couple different options there with how to prevent that steroid withdrawal. Moving on to mineralocorticoids, and these are also secreted by the adrenal glands, specifically aldosterone. These are responsible for fluid balance within the body. Aldosterone secretion leads to reabsorption of sodium. Where sodium goes, water follows. So when I say reabsorption, that means the body's getting it back from the kidneys. However, when the sodium comes out of the kidneys and the water comes out of the kidneys, we are pushing out potassium. So what's happening with aldosterone is we increase sodium, we increase water, but we lose potassium. The drug that is used for somebody who cannot make their own mineralocorticoids or aldosterone is fludrocortisone, and that's used for replacement therapy. It's a chronic thing, meaning for the rest of their lives. So we give that to the patient a couple times a week, maybe even every day, depending on how their body responds. Adverse effects are exactly probably what you think they're going to be: potassium depletion and water retention. It's not always a good thing in the case of congestive heart failure or edema or hypertension. So those are all adverse effects, and that's strictly due to the water being retained, which in someone who can't do it for themselves is a good thing, but it can sort of have an adverse effect if we've given them too much of the drug. So we use steroids with caution in patients with a GI history and ulcer history, because it can irritate the lining of their stomach. We also use it with caution in renal disease. I had mentioned congestive heart failure, as well as patients with psychotic tendencies because of the roid rage sort of side effect that can happen. There's also a variety of drug interactions, and those are covered on page 611. Specifically, if you're giving steroids to a patient with diabetes, they're going to have an increased insulin demand because they're going to have more glucose in their body now. If you're giving these medications to someone who is also getting a potassium depleting medication, such as a diuretic, they may require potassium replacement in addition to the medication you're already giving them. And the last important one they mention is warfarin. If somebody is on warfarin or Coumadin, they may require an increased dose if you're also going to give them steroids, because steroids sort of, patients receiving warfarin may have a decreased warfarin response in the presence of steroids. So we always want to be careful, because in that case, warfarin or Coumadin is a blood thinner. So if we are decreasing the effect of it, we are exposing that patient to possibly having a blood clot, which could be very, very dangerous. So that's that chapter. Hopefully this lecture made a little more sense. I realized after the first couple that I was having a little bit of trouble following the book, so I made my own notes on this one. If you guys have any suggestions or questions, let me know, and we'll be moving on to chapter 38 and 39 later on tonight after I get out of work. Apologize ahead of time if I'm extra tired, and if you guys have any questions, email me. Probably the best way to get a hold of me. I'll be checking it about 2 p.m. today. Thanks.